Hello, a very good morning to everybody. Very glad to be here. I thank Dr. Arun Kumar for this wonderful share our knowledges in each other in this lockdown period. I wish all the participants and stay blessed, and we together will learn each other in the field of mental health. I wish you one. So today's topic is a very good topic and a vast topic. Okay, that is a little bit previous era. Schizophrenia is a very global burden disease actually. So occupational therapist from a different scenario. So we have a little bit question mark. So what are the therapeutic base, or what are the knowledge base we want to be share, or we want to be advocate to treat schizophrenia. Okay, so a lot of the researchers and our pioneers speculated the hypothesis and proven through evidence-based practices. So today we are going to be look that kind of one very evidence-based proven topic. Impact on centration advocate occupational performance in schizophrenia. So today we are going to be look over general schizophrenia, occupational performance, disorganized speech, and loosening of association, because the talking, like the conversation, it's not associated when one thought is not connected to another. Okay, so it does not match, it does not have a logical sense. Okay, and a little bit hyperactive behavior, inappropriate affect, blunt affect, we used to say, and suspicious, hostility, and all. Negative symptoms, that is poverty of speech. There is the speech is a little bit, like allogial, there is very less content of the speech is there. Affect blunting, there is expressionless face. Apathy, loss of interest, lack of motivation, evolution. Anhedonia, there is inability to experience pleasure. So there is space. If any happy news is, we used to say there is no pleasure, there is no exclamations in the faces. And attention impairment and memory deficit. So these are all the positive negative symptoms is because of the chemical imbalances of the brain pathology. So we're going to see one by one. These are all the criteria for DSM-5 now. One, because we've seen before the symptomatic symptoms, the 2 or more of these symptoms, it lead at least it's prolonged 1 or 2 months. It's said to be like all at least one symptom must be either 1, 2, or 3. See, look over hallucination, delusion, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms. So you can go and see the DSM-5 criteria. According to this criteria, we will diagnose the schizophrenia. Okay, and continuous disturbance for 6 months, it's said to be maybe residual phase and attenuated phase. Again, social and occupational, this is, they are telling about more in the constitutive organism, social and occupational dysfunction. So why we are here today to discuss about and to learn about the occupational performances. Yeah. See, we used to say schizophrenia first rank symptoms Schneider. The Schneider, Kurt Schneider, she said, because there is 10 to 11 symptomatics is there. So this is called first rank symptoms. So you can see the picture. There is, the delusion and hallucination in between, like delusional perception, delusion of the control, the voice coming from the body is controlling, okay, and voice discussing the patient, voice giving running commentary, go and do that, you go and do that, like that. Thought insertion, somebody is inserting the thought and he do so. Thought withdrawal, so he is inappropriate and he is making aloofness in this world, like that. Thought broadcasting, somebody is talking, two or three people are talking in front of, he is talking about me in the TV, he is used to see some of the advertisement or something, no, my thought is broadcasting there, something like that. So these are all the fresh symptoms of Schneider. Okay, they said like audible thoughts, voices arguing, voices commenting on one's action, somatic passivity, thought withdrawal, thought insertion, inserting the thought inside. So why you are doing this thing? Maybe the person take the knife and going to kill. No, somebody is the one voice I'm hearing. He said, I want to kill them. Like that. So it's very inappropriate behavior. And made volition and made effect and made impulse, delusional perception, and so on. Hello, Jonathan, is it okay? The connection is stable?
Yes, sir. Hello.
Yes,
Okay.
sir,
Yes,
you can continue.
Thank you. Thank you. So coming to the, yes, thank you. The phases of schizophrenia, there is three phases: prodromal phase, active phase, and residual phase. Okay, so we can say the prodromal phase is the initial phase, active phase is the middle phase, and residual is the chronic phase. You can see in the slide, so they experiencing adapt or declining the adaptive functioning. Once the person affected from schizophrenia, they are declining the occupational functioning, and the emotional and behavior problems is increased. It stays some days or some months, like 15 days to 30 days, like that. It stays to 1 month. They used to say he is in prodromal phase. Okay. Then coming to the active phase, this is an episode of more than 1 month, at least more than 1 month. A lot of positive symptoms. What we've seen, the positive symptoms: hallucination, delusion, disorganized speech, catatonic behavior. These are not. So the catatonic behavior, like they are immobility, their faith, their movement is to be, the restricted movement. They are immobile and backside flexibility. These kind of features in catatonic. They used to say catatonic. Now, a lot of prevalences is more of the hospitals is they telling that catatonic schizophrenia. And residual phase, also positive symptoms is there. They disappear or may appear, like that. The positive symptoms decrease and the negative symptoms is coming up. Okay, we know negative symptoms, withdrawal, social withdrawal, apathy, these are the things. So it needs to decades, like this residual phase. So it will be come up the phases. Little bit more clear, you can see the slides. Okay, the prodromal, as I said, marked decrease in the function. So that's what I said. We are here to discuss about how the normal function and dysfunction of the human being and the schizophrenic function and dysfunction into the occupational performances and all. So in acute phase, 1 to 6 months, it's psychotic symptom, and the recovery state is both. It's together, and a little bit impact functioning is remain, like that. So residual, some positive symptoms, negative symptoms persisting. Okay. So the brain in schizophrenia. So today we need to be concentrate. Brain is very important. Okay. So after the schizophrenia, how the brain of schizophrenia will be. Okay. So look at that. See the auditory system, because the imbalance, I said the imbalances of the neurotransmitter dopamine and GABA aminobutyric acid and glutamate. These are all the it will give the excitatory impulses and inhibitory impulses towards the cortex for the functional thing. Okay, that's a brain matter. rich role in schizophrenia. That's what the system is inappropriately functioning. Okay, so why the schizophrenic patients cannot able to be do their roles and routines as well. So there are dysfunctions in their domains of occupation. So see, the auditory system, usually it enables the humans to hear and understand the speech. But in schizophrenia, the overactivity of the speech in the vernix area will create auditory hallucination. So there is one we are going to see about sensory gating. So all human being having sensory gating properly, it will give, it will produce fine amplitude to reach our inner ear. Okay, so in schizophrenia, the sensory gating difficulties, it will give a little bit inappropriate signals. So the illusions and internal generalized thoughts and the voices of things is coming from outside, it's saying. See, the occipital lobe, this main processor, it's processing information to the visual world, okay? But in the schizophrenia, but the disturbance of this area, it continues difficulties interpreting the images, okay, and recognize the movement, okay? So I cannot recognize the emotions, I cannot recognize the faces I can see. So these are all it's made very important dysfunction. Hippocampus, what it says, it will do the mediates learning of memory functions. So it's mediate the memory again. So again, the impact of the schizophrenia, do the all the memory things will be impaired. Coming to limbic system, it will give the emotions. We know limbic system, the brain, it's play a very good role of emotions, but disturbance of this area, it will agitation and frequently seen in schizophrenia. So that's what schizophrenic people, persons agitated very easily. Frontal lobe, it's a thinking area. Okay, so the critical problem solving, it's normal human being. We are thinking, like critical thinking all through frontal lobe only. So insight and all, higher cortical reasonings and all. So the perturbations on the defective of this area due to schizophrenia, it leads to difficulty in the planning, actions, and organizing thoughts. Okay. Coming to basal ganglia, it involves movement and emotions. It will be integrated. So through these functions happen, the dopamine receptors, the blockade of the dopamine receptors, it's give the side effects also. Okay, so we'll be learn today what are the blockades and what is neurotransmitter level and all. Okay, so these are all the clinical. I mean, we want to be physiological patterns behind the schizophrenia. See this again, the thing. Okay, so this picture, this is brain. Okay, so prefrontal cortex. So this is prefrontal cortex. It's too little dopamine release results of negative symptoms. So okay, through after the signals is not properly transmitted. Okay, so see, look at that healthy brain levels and schizophrenic brain levels. So this is GABA aminobutyric acid, glutamate, and dopamine. These are all the neurotransmitters in the brain. Okay, some of the excitatory signal, glutamate passes the excitatory signals, GABA aminobutyric acid passes the inhibitory signals to the brain. Okay, so this is healthy brain. Coming to the schizophrenic brain, so the impulse is stop. That is stopping transmitting the signals. Okay, you can see this nuclear. You can nuclear accumbens is too much dopamine release cause positive symptoms. Prefrontal cortex is too little dopamine release, so it causes the negative symptoms. Okay, so this the interrelated play is very important for the normal human being brain. Okay. So dopamine pathways relevant to schizophrenic symptoms. How and all, you can see the we have two pathways, mesolimbic pathway and mesocortical pathway. Okay, so the mesolimbic pathway is a collection. See this one. It's a collection of dopaminergic. There's a dopamine release neurons. So the collection of neurons, the project to the ventral tegmental area to the nuclear accumbens, okay, or ventral striatum. So this activity, if it is normal, there is no problem. If it is overactivity, overactivity of the mesolimbic pathway, it causes the positive symptom. Okay. Yeah. Coming to mesocortical pathway. So the mesocortical pathway, it is one of the four major dopamine pathway in brain. It connects the ventral tegmental area to the prefrontal cortex. This is ventral tegmental area to prefrontal cortex. So this mesocortical pathway dysfunction leads to negative and cognitive symptoms of schizophrenia. Why this is happening? So during the signal transmission, there's a delay in the transmission is there. Okay, so you know the neuromuscular junction, the neurons while carrying the signals. So after due to the symptomatic and due to the genetic predisposition, causative organs, and some of the research says antipsychotics and SSRI, they used to give more SSRI, these are, it will be given a result of more activity of the limbic system, and the cortical dysfunctions also is there. So that also one of the major thing we want to be look over. Okay. Hope you understand the schizophrenia now. Okay, coming to occupational, this interrelationship between the person, occupation, and environment. Okay, so nowadays, without one person, we have a three denomination: the person, occupation, and environment. So the in between three-person involvement, it will produce the occupational performances. So the ability to perceive, desire, recall, plan, and carry out the roles and routines, tasks. There is subtask is there. Okay, for the purpose for why self-maintenance, productivity, leisure, rest and response to demand, internal and external environment. So this is a definition. This is all it's coming up to give the occupational performances. Occupational therapy practice framework. So American Occupational Therapy Association officially document to guide occupational therapists understanding of various domains of practices. Okay, so nowadays it's mandatory, not it's a practical ethics. We want to be follow these guidelines because we are occupational therapists. We want to be more concentrate on occupations. Okay, how we are in the client-centered or medical model, whatever it may be. So we want to be concentrate on occupational therapy framework. So this is highlighted by American Occupational Therapy Association. So it provides the reference for the common process of OT to display variability of the practice. So it is very important. This is divided into two, the domain and process. So domain, what is domain? It's the areas, okay, areas of occupations. So the occupations, client factor, performance skills, performance pattern, context, and environment. So these are all the domains is very important for one human being interactions to lead the successful occupations in life. So as I said before, the person, occupation, and environment, the interrelated interplay a very good role because of the occupations needs client factor. Client factor plays performance skills and performance pattern interrelated. So these are all need stimulants coming from context and environment. So if one is missing, the occupational instability or performance is problematic. Okay, so this is the domain says. Process, there's three things in the process: evaluation, intervention, and targeting outcomes. Okay, so today we'll be seeing one by one. Occupational therapy domains, as I said, what are the domains? Occupation, you can see the picture, see ideal, work, play. We occupational therapists, we are dealing with all those things. I know maybe the students and respective therapist or maybe other participants, you know these are all the things is a problematic area today. The patients are coming to you from the school-going children, so he's not going to school properly, he's not able to write properly, okay, and he's not sleeping well, okay, and now the lockdown period is there, okay. The students are automatically, they are not attending online classes, they are always playing it in the cards, and also they cannot able to balance between all those domains, okay. So see, all those domains, there is definitely the client factor, performance skill and patterns is very important. That's what world of occupational therapist said occupation and expected to do. So they want to, the people, the person want to do actually, okay, they want to be, this is what we can say self-advocacy. The people, the person want to come, they want to say their desire and outcome actually. So this is the, we are asking, you know, patients, what is your priority? Okay, what's your concern? You're coming here as an occupational therapist, you're coming to me, what's your concern? Okay, so this is very important to nowadays occupational therapists want to keep it in your mind if you are practicing on the domain as well as properly or not. Okay, so for the families and the communities, it's very important to do the purposeful and to meaningful participation and engagement in the life. Look at all those things as we see in the client factor, the occupations, we know all those area, and client factor values, beliefs, and spirituality, body functions and body structures. So we know, okay, we are here, we know what are the structural deformities or structural formations in the brain, I mean in the body, human body. And the functions, you know, if I want to be take my pen, and taking my pen means I want to be flex my head, you know the functions, what functions and elbow flexions and all is there. So for this functions, what's my value? What's my, I want to value my occupation, okay, because I want to be take leisure means I want to valuing my leisure, I want to plan my leisure, right? So this time I want to be sit and I want to be participate my leisure, something like that. So first we keep in your mind what is the normal functions, and we go on with to the pathological. So how the pathological brain is accept these or all domains in their life. So we occupational therapists want to be keep in our mind these when patients is coming to you, whatever the denominations you are, what are the area you are, doesn't mind. You are maybe from pediatric, you are maybe from neuro, you are maybe from mental health or general practitioners, doesn't mind over it, but you should think about these are all the scenario in your mind. You should put in your mind like that. What are the client factors and all. Performance skill, as we motor skill, process skill, and social skill. Okay, according to these occupations, definitely, if I can say the leisure means I want to process my skills, right? So in the process, there is some of the functionings is there, okay? You know, neuromuscular functions and cognitive functions and mental health functions, context and all. So this is very important. Performance pattern, habits, routines, rituals, and roles. So this is what is our habituation? Our regular behavioral practices, our habituations. Okay, and our routines. See, if we are today, we are more than 3 to 4 months. We are in the due to COVID-19, we are in the lockdown. So definitely our routine should be definitely to be affected, right? So as we know very well, you can analyze yourself. What was my previous routines, what's my routines right now, what's my rituals before, what's my rituals right now. I think you are playing your role very well. I think daughter role and son role and what father role, grandparents role, whatever it may be, you are playing your roles as well. Because why? Because your context is very important. You are mingling with the context, okay? You are cultural, you are personal, and the physical, social, temporal, virtual context is very important. Now you are in the fine context environment, okay? So nowadays they are starting up, even I'm talking about 1 or 2 months before, okay? So performance is very important. We keep it in your mind: occupation, client factor, performance skill, performance pattern, and context and environment. So we finished the domains and occupational therapy process. Okay, so look at this occupational therapy process. It's a collaboration between the practitioner and client. Okay, so it's divided into evaluation, intervention, and outcome. Okay, in evaluation there is two occupational profile of the patient, and I'm analyzing of occupational performances. How I want to be analyzed the patient's occupational performances. How I want to be take the occupational profile. I know you all mastered in it, and maybe the budding students and the learning students, I'm telling. So occupational profile is very important. The interview process is very important while planning the interventions. Okay, so that's what we have this like of profile, this like of domains they are giving. And in intervention, see the intervention plan, we need to be planned, we need to be implement, and we need to be reviewed. Why plan, implementation, review needed? Okay, so I'll give one example. In my earlier days, I said maybe more than 10 years or 10, 15 years before, I was in a practitioner in one hospital. Okay, so the pediatricians or psychiatrists refer the cases to me directly. Okay, then what I'm doing, that's first time, So this, I'm seeing the patients and fast, I want, because there is very limited time. I want fast interview, and I just give what the problem. Okay, you cannot able to flex your, fingers. Okay, what I can do, just like that, my brain will be go. Okay, so I'm evaluating anyway. I'm not collecting the clear occupational profile and not analyzing the occupation. That is very, very important. Okay, on how I want to analyze the occupation. Okay, for let's say I can take the in self-care, bathing. Okay, bathing, I want to split the bathing activity analysis. So the third year and for third year, maybe second year BOT students, you will be doing it, that break down the task. Okay, I want to break step of the activity. In the step of the activity, what are the body functions is affected? In the occupation, what's my client factor is affected, and what's my performance skill is affected for the body, maybe 5 steps. Okay, I want to collect my stuffs, I want to open the bathroom, I want to go inside, I want to open the shower or tap, and I want to be, everything. Okay, so these are the steps I want to be process or not. Business analysis. Then I want to plan, I want to implement, I want to review. Why review is very important. That's what I'm saying. I'm failing a lot of the times and before my earlier practice. So why? Because I'm not reviewing my interventions. So I just plan it, I just implement, I plan and implement. Sometimes I'm not planning and I just implementing. Okay, so the reviewing is not there. So I'm not getting any results. Why it is like that? So then everything will be fed up. Okay, occupational therapy is like this. So, and the doctors also used to say, right? You'll be come across this kind of way. So please change your pattern of practice from today. Okay, so intervention plan and the implementation review is very important. Okay, I want to review the plan. Okay, this is not right. Okay, I want to apply this one. All trial and error learning only. Okay, then coming to outcome. Outcome also, select the outcome measures is very important. How I'm selecting the outcome and applying the outcome measures also is very important. So after 16 session, what it will come. Okay, so that's what we are. We have a very good thing. We are planning the short, long-term goal and short-term goals. Okay, what's my plan after that? What's the patients after going after discharge? Okay, this is very important process. In evaluation, as I said, we need to be collect the client's background information. Who is the client? Okay, what is he? Okay, what do you want from here? The history of the patient, birth history, medical history, personal history, social history, lot of things. And personal concerns and value is very important. You can ask him, sir, how psychiatric patients tell their concern. they are probably inside, and we are good occupational therapists. We have a question like this. So personal concern and values, how, why, when they will say and how they will say. That time we can take the history from the caregivers actually. Okay, so and we need to be talk to them. That's what I said. The acute phase and then prodromal and residue and that phases. That phases. But we need to be. That's what client background information is very important. From the file in the hospital, you can go and look over the file and you can get an idea about that. Or else the patient is coming to your clinic. First of all, spend some time, maybe 1 week, doesn't matter about it. So the profile is very important to plan over the therapeutic measure. Okay. And the client priorities and the desired outcome. We want to be asked what you want to do. What is your desired outcomes and all. Okay. So as I said, analysis of occupation performance is dynamic interaction between the client, context, and environment. Okay. As I said, activity analysis and activity synthesis. Activity synthesis, what are the object we are using in the activity. Okay. So what are the space demands is there? Okay. The space having adequate lighting out there. Okay. What's my synthesis is right now? So I'm having a lot of, airy, lighting, okay, and like proper arrangement. This is synthesis is very important for occupational therapists to deal with things. Okay. Coming to intervention part, this all based on occupation. So intervention, I said to develop a plan actually. In the develop of the plan, we need to be considered the discharge needs. So while the patient is coming to me, I will discharge the patients, right? So this is we are think very good hope, right, for the patient. So I want to be considered the discharge and what of the discharge plan for my patients. Okay, for the schizophrenic, for the chronic schizophrenia, they are debilitating, they are devastating in their daily living skill. So how I can make the patient independent in self-care. That's my, after 6 months or after 3 months, the patient can able to do independent brushing. The patient will be able to do this thing. Okay, this consider discharge notice is very important. Then select outcome measures and make recommendations. So this is the, you should put the intervention plan in your plan sheet. Okay. Then intervention implementation, there is different types of OT intervention. See that, look over the, we need to be, this is the terms we are using in the OTPF model. So previously we used to say the intervention plan, sensor integration therapy, okay, and the cognitive behavioral therapy, group therapy. Yes, that are all interventions, I accept that. These are not intervention implementation, but the process, what I want, I'm going to do in the patients. Occupation therapy intervention types are there actually. So this is, I will create and promote, what occupational therapist environment, how we occupational therapists want to be do into the, for the patient in occupational performances. So to create or promote the health promotions, I will see. To establish, okay, maybe my treatment is based on remediation and restoration. My treatment is based on maintain. My treatment is based on modification or compensation and adaptation. My treatment is based on the prevention or disability prevention. Hope you all understand this, or you're all following me, I think. Okay. If any doubt, can please, the end of the session, please raise with your all doubts, and I'm sure I will be stand with you. And coming to the intervention implementation types, there is therapeutic use of self, therapeutic use of occupations and activities, that is occupation-based interventions. What is occupation-based intervention? Because we are occupational, we are not physiotherapists and psychologists as well. We are occupational therapists. My treatment is based on occupation. Okay, fine. I just come to the clinic, the patient is coming. Okay, do the range of motion. No, in the range of motion or in the relaxation activity, or in the, let's say, the mental health term, in the diversional therapy. So what activity I want to be do to them? So listening music. Okay, so they are sweeping, they are bending and sweeping, and all the senses of involving and to listening the music. So I'm diverting to music to incorporate or modify or restore their functions actually. So this is occupation-based intervention, which is very important. And purposeful activity also. So our occupational therapy, sure, we are doing purposeful activity. This is what we are different from other peculiarities. Okay, and preparatory methods. We want to be patients in occupations, through occupations, then consultation process, education process, group advocacy. Okay, so these are all the implementation methods. So how I will be review is very important, my dear. So we need to be re-evaluate the plan actually, modify the need. That's what we asking that client priorities, desire outcome. Maybe the patient say, I want to be, he's a bank manager getting affected with schizoaffective disorder for the prodromal state for the 1 month, and he's getting medicine, he's coming to you as an occupational therapist, mental health occupational therapist is coming to you, and his priority, I want to be back to my work, back to my job. So this is very important to the patients, for the therapist to think over, to review the plan. So my occupation, my plan and implementation based on that. So I'm going in that, in between, what obstacles is coming, I want to be take over. So this is very important to think over the review, okay? Or to determine the need for continuation or discontinuation of services or referral. I stand with you because all the patients, whatever we have good hurts, this all patients I can treat. Yes, definitely. Some patients we need to be discontinued the services. Some patients we need to be referred to someone else. Okay, maybe some other areas for the speech therapist, for the psychologist, yes, psychiatrist, in between psychiatrist, yes. So how I will discontinue this program for 2 months for the medicine, medical therapy, then I will be retrained for. So the review is very important. Hope you all understand. So the thing is the demands and outcome. So let's see the patient achieving the health, well-being, and participation in the life through engagement in the occupation. So my outcome focus is based on the health, participation, and engagement in occupation. I said my example, my earlier days of my practice, I said many times as an occupational therapist, I failed to show the prognosis of the patient. Why? Because I'm not concentrating on the outcome of the patient's focus, the health. It's very important. Okay. So I just want to be health condition is okay. For this occupation, the patient is eligible for my participation. The client is did the client is participate the perfect activities, purposeful activities or not, and engagement in occupation. The client is engaging. Sometimes the people is not engaging. Simply they're sitting like so. What thing I want to be making, and maybe socially lagging, okay, maybe apathy, maybe logia, okay, maybe the negative symptoms, social withdrawal. What I want to be get rid of all those things to make engagement to the patient's client. So this is what's emerging between the occupational performance advocacy in schizophrenia. And how I select the types of outcome measures: occupational performance, adaptation, prevention, health and wellness. I want to be concentrate on the quality of life of the patient. I said participation, engagement, self-advocacy. I said this is we want to give some chance to the patient, client priorities and client directiveness. I said so, self-advocacy and all. Okay, so role competence and occupational justice also. So the patient have rights to choose the activity. For example, I'll give an example. Nowadays, the disabilities, all in wheelchair dependent, they get the government job as well. So this is occupational justice. Due to this pathological background, there is no way we want to be stopped. No, you should not do that work. We are not supposed to talk like that. Okay, so occupational justice is very important. Wherever, whatever in Western countries and all, they are having a licensure agency is there. The patient's coming through the agent only. Okay, so after the treatment, patient want to be patient have taken over by the agency. Agencies have getting the jobs and home environment and everything. Actually, adaptation, architectural barriers, and so on. So this is occupational justice is very important. I will think my outcome. Okay, and measures the outcome goals. These are the targeting, evaluation process, intervention process, and targeting process. So all those things, environment and context is very important. So that's why I said client, person, activity in occupation. So in between the environment also, it's very important. Hope you all understand. You are following me. Okay, so far occupational performance is done over and sensory integration. 1 minute. Jonathan, can you hear me now? Is it okay?
Yes, sir.
Okay, yes. If you're not audible, please let me know.
Okay.
Hello,
Yes.
sir. I think it is little low, sir. Can you check your mic, sir? Hello?
Okay, yeah.
Yeah, sir.
Yeah. Okay.
Okay, sir.
My voice is low a little bit, right? Now it's okay?
Yeah, better, sir. Yeah, thank you.
Yes. Yeah, thank you. Yeah. So sensory integrations, as we all know, Dr. Jean Ayers is a pioneer of sensory integration in the year of 1960s and in 70s. Okay. So sensory integration is a theory and practice model initially developed by the occupational therapist Jean Ayers for the treatment for learning disorders in children as well. Okay, this is the first innings of Jean Ayers. Nowadays, it's developed a vast country. I mean, vast development. It's giving a challenge for some of the professions as contains occupational science there and talking about according to the evidences and all. Okay. So it's a term refers the way of nervous system receive the messages from the senses and turns them into appropriate motor and behavioral responses. Okay. Sensory integration is a theory of brain behavior relationship. Okay, so it's based on the neuroscience how brain operates. Okay, so we are very glad and we are very happy, proud to be say occupational therapist only handle very successfully sensory integration. So there are a lot of denominations they're using, but the main occupational therapist, this is very important to know that. So practitioners, please try to implement and follow the sensory integration principles in your practices. Human senses, five external sense, touch, visual, auditory, olfactory, gustatory. The two internal senses as vestibular and proprioceptive. So as we know, vestibular and movement is information of the movement through the ear. Okay. And proprioceptive, it's a body awareness, information from muscles, ligaments, and joints. Special internal senses is very important and play a very integral role in schizophrenia. Okay, this is the sensory integration development. Okay, so see the pyramid of learning how senses is developing. The system is the basement. Okay, through this, okay, all the sensory system like external and internal senses, tactile, olfactory, visual, auditory, gustatory, and vestibular and proprioception is developing. Okay, so this is we are talking about development. After that, sensory motor develops. What is that? Body screen, reflex maturity, ability to screen input, motor planning. I think the terms and all definitely you'll be understand. Okay, you are all maybe third to fourth year students. You maybe understand awareness of two sides of the body, postal security. So there is interconnections between the senses and the reflex maturity. There is reflex persisting or debilitating. It's due to sensory actually. If the sensory development is properly done, the reflex maturations will be. So there is a lot of study also is there. So the sensory deprivation is there, definitely reflex and maturation is there. So the sensory and the integration and reflex maturation, reflex integration, not that perception motor develops with auditory language skill and visual spatial attention, center function, and hand coordination, motor control, postural adjustment. So this is level 1, level 2, level 3, like that. And in cognitive intellect. So these are all developed, the development of behavior, academic learning, and daily living activities. So for the daily living activities where we are occupational therapists, I'm very proud to say, and the cognitive area, the daily living skill, it's in the pyramid. So that's in the level 4. We need to be look over all those. So daily living skills is not properly need to be the person.
Hello, sir. Vinith sir, sorry to
What the
interrupt.
sense? Yes.
Sir, your
Yes.
voice is
Yes.
much breaking now, sir. It's
Oh,
not much
really?
audible also. Yeah, yeah. Breaking continuously. There are
No.
fluctuations also. Yeah.
Okay. Is it okay now?
Yes, sir.
Hello.
Yes.
Hello, sir.
Maybe the internet facilities maybe it should be like. Is
Yeah,
it
yes,
okay
sir.
now?
Yeah,
Is it
better,
okay
better,
now?
sir.
Oh, okay.
Thank
Yes.
you, sir.
Sorry.
It's okay. Thank you, sir.
Okay. Yeah, fine. Thank you, Lindsay. So these are all the levels of development of the sensory integrations. Okay, so as I said, we are in the cognitive intellect area, daily living activities. We need to be completed all those level 1, level 2. So look at that, level 1, level 2, level 3, and all. Okay, these are the development. The same thing IS original model, you can see the level 1, see the visual, tactile, proprioception, vestibular, and all. Look at the second level, the same in the visual, mother-infant bonding, the tactile, sucking and eating develops, the vestibular proprioception, eye movements, posture, balance, muscle tone, gravitational security, okay? The third level, the tactile, emotional stability, attention span, okay, and the motor planning and everything, okay. The fourth level, speech, language, and vestibular eye-hand coordination, tactile, visual perception, perceptual activity. At the end products, what? We need to participation in daily life. What is that? Ability to concentrate, ability to organize, self-esteem, self-confidence, academic learning ability, capacity of abstract thought and reasoning, specification of each side of the body and the brain. Okay? Now it is okay. Okay. Yeah.
Sir, in
Yes.
between, it's a little bit of breaking, but better than before.
Okay.
Okay.
I think the connection of internet facility.
Yes, sir. Yes. Yes.
Okay. So sensory integrations are such. Okay. So there is sensory nourishment, neuroplasticity, developmental sequence, and nervous system hierarchically, inner drive, adaptation response. So sensory nourishment, it's the stimulus from the environment. Okay, neuroplasticity, like to we need to be have an end product as well. There is intensity, frequency, and durations. There is a reorganization process is through the activities that. So neuroplasticity is one of the assumptions in sensory integration. So the sensory integration is developed through developmental sequences. As we know, our development from the neck control to walking and running. So it's actually, and it's hierarchically. It's not hierarchically the sensory signals from the spinal cord to midbrain, and midbrain to primary somatosensory cortex. Okay, so this is hierarchically from the spot area to the brain. And inner drive also is there. So what the patients want to be, it's very important that client directed. So inner drive also, it's very important. Adaptive response. So we'll be look over more adaptive response, because sensory experience and adaptive response is very important in sensory integration. So what sensory experiences I want to be do and what's my outcome is there. Okay, that's adaptive response. Okay. So these are all the sensory integration process. That is input, processing, and output. Input, processing, and output, because input, I said the stimulus from the environment. Okay. In the processing, the registration, filtering, modulation, planning, response. Okay. So response is coming from output. So just put it in the mind while you are handling the patients. So my input is very important for the processing. Maybe first for the therapeutic planning, I said to occupational performances, how I can merging sensory integration principles and occupational performances. So my intervention plan, so the patients are right now in the processing phase. Okay, so how I want to be work on registration and filtering. Okay, that's one of the example. And maybe the end of the phase, yes, I am right now in the output phase for the response. Patient is responding now. Okay, so this is important for the processing, sensory integration processing. Okay. Another 4 principles is the just right challenge. Yes, it's very important. So we want to give the just right challenge for the patient. Okay? What the client wants to do. Okay, the client must to successfully meet the challenges in engaging activity. So we want to give some made challenges for them. It's very important. Then adaptive response. The new or useful activities presented. That's what I said. Adaptive responses very important. And active engagement. The client will want to participate because activities are meaningful. And purposeful, meaningful activities is very important to plan the sensory integration. So the principles is based on that only. Then only we can have a successful thing. Okay, client directed. So the activity should be on client directed. So it's not therapist directed. Sometimes nowadays, previously also patient directed. Therapist directed. It's not therapist directed. It's client directed. It used to be a patient to do what they are doing, what he or she is doing. Okay. Yes, we all know in sensory integration, sensory profile is very important assessment tool. Okay, we're talking about sensory, schizophrenia. So we are using adolescent and adult sensory profile. Okay, so this is a profile sheet. Okay, so based on that, we need a model of sensory processing, and it's a self-reporting tool used to find the responses to the sensory experiences. I said very earlier, don't worry about insight of the patient, schizophrenia and all. So you can get the it's a self-questionnaire. You can get there is one of the internal is there. You can get this from the caregivers or the nursing practitioners. Maybe the patient is admitted in the ward. The scale has 6 items of 60 questions divided into 4 quadrants as low registration, sensory seeking, sensory sensitivity, and sensory avoiding. So moreover, so how the patients will be. So, you can see this example, what the self-regulation continuum, we used to say passive to active. The neurological threshold is high threshold to low threshold. So I can say the registration, if the low registration is there, need additional input to respond to the stimuli, but take to passive approach. We want to take, if it is low registration, we want to take a passive approach. It needs to do it. Okay. For example, they said, I don't seem to notice it when my face on hands are dirty. My face is dirty, so I'm drooling. This is low arousal level. say low registration. And to seekers, how the schizophrenia, so does it need additional input to respond to the stimuli and actively seek a little bit hyperactive? So they are seekers. So I think to attend events with a lot of music, they need more like that. So need market more stimulus. Okay? Let me see avoiding. It respond readily to low threshold stimuli, but avoid stimuli. Like they are responding little bit stimulus. They're very picky eaters, specifier one. Okay, I only eat the familiar food, so they are called avoiders actually. Well, maybe you're coming through this. You're not new to this thing. So I just correlating something. It's not all in schizophrenia. Some of the patients they are highlighting. That's what I just highlight that. Okay. Vinci, is it stable or can we stop and can we continue again? Is it
stable now, sir? Yeah.
Oh, okay.
Yeah.
Okay. Thank you, Vincent. Okay. So, and sensitivity, it's respond readily to low threshold stimuli, but does not actively avoid stimuli actually. So, for example, I startle easily at unexpected or louder noises. So this is very sensitive. I cannot bear that senses. I cannot bear that smell like that. So they are very sensitive. So this is very important in the adult sensory profile. Okay. There are three key for sensory integration intervention. Frequency, duration, and intensity. As I said, sensory experience with adaptive response, both together is very important. If we are doing one activity, we are selecting one occupation to deal with sensory integration module to delete the patient. So the sensory input is very important. Sensory receptors are stimulated. So if it's stimulated, it will process through the information, organize, interpret, store the previous experiences. And the response is generated. Response through adaptive response. So the sensory input and process is through sensory experiences, and through it will produce the adaptive response. So all these three is very how frequency we are doing that thing, because as I said, the blockade of the neurotransmitter, it stopped the delay. It stopped the relayness. The transmission is stopping due to the blockade of the signals. So how frequency, duration, intensity we are giving the sensory integration to the schizophrenic patient is very important to prompt their activity. Okay. And to encourage the occupation, to engaging the occupational therapy, occupations practices. Okay. So now, yes, we finished this thing and we are coming to how the sensory processing difficulties or how sensory processing skills in schizophrenia. Okay, so the sensory processing abnormalities are routinely observed in patients with schizophrenia. The type of abnormalities range from disturbances in the sensory gating, I said, because this sensory gating gave the disturbances to the visual information processing. Then the adult schizophrenia has experienced typical neurophysiological responses to auditory and visual stimuli, both mismatch, negativity, and sensory gating. So today, maybe this is something you may hear, something maybe new. Just a little bit listen to the sensory gating and mismatch negativity. These two things occur in schizophrenia. So already the neurodevelopmental chemical imbalances, causative factors is there to stop the sensory thing, and this sensory gating and mismatch negativity is also okay. So what is gating? Sensory gating is an ability of the central nervous system to adapt to the sensory stimuli upon their repeated presentation. So look at this picture, this is a case of overstimulation. So this is gating. You can see the girls responding, how she's, because the amplitude, P50 wave amplitude, we used to say event potential, active event potential, auditory event potential, and auditory evoke potential. So this is from the environment, it's not coming it's readily organized. So it is overloaded. It's called sensory overloaded. Many schizophrenic patients may relate to inability to concentrate because of this imbalances of the sensory overload gating. Okay, yes. So that's what its tendency to deficit in the more prominent frontal areas of the brain. Okay. Mismatch negativity of the schizophrenia. Look at that in the graph. Okay. See, mismatch negativity is an auditory event potential that provides an index of automatic content dependent information processing and auditory sensory memory. Okay, so it's if the AERP, this is auditory event related potential, is properly processed, there is no auditory sensory memory deficit. So if it is due to that causative organisms, so causative factors and etiological background and neurotransmitter thing, so it will shows the mismatch negativity in the schizophrenia. Okay, MMM may index ongoing neuropathological change in the auditory cortex of the schizophrenia. This is very important. Look at the deviant and stranded waves. So the amplitude waves is not correctly contacted, produce the signals to receive the information processing and auditory sensory stimuli. So coming to our sensation patients of schizophrenia. So I love this author very much. Hope you all mental health occupation therapists, you come across this Lorna Jean King. She only speculated the sensory integration principles application for chronic schizophrenia. Okay, so she was lifelong educator and innovative practitioner, pioneer in applying sensory integration to occupational therapy interventions for autism mainly, and secondary to learning disabilities, and third to chronic schizophrenia. Okay, what said she said the schizophrenia have these 6 type of proprioceptive difficulties. So she only speculated very clearly the 2 senses, vestibular and proprioceptive difficulties, is more overseen in the schizophrenic patients. You look at the patient. Okay, these are all movement pattern observed in the chronic schizophrenia by J.L. King and S-curve posture. So look at that. This is S-curve posture. Okay, when the head and neck are flexed, the shoulder rounded, abdomen protruding, pelvis stripped. Okay. Yeah. Okay. Then shuffling gait. Look at that. A style of walking with feet constantly in flat contact with the floor. Difficulty raising the arms overhead. Now if you see schizophrenic patient, you put it in your mind while they're walking, their arm swing is very less. There's arm swing. Okay. Just down actually, it's resting posture. Okay, and head and shoulder girdle immobility. There is no movement in head and shoulder. Okay, so the resting posture always, I said, the shoulders and hip are flexed, adducted, and internally rotated in sitting and standing. So while you're walking, it's adducted. The resting posture, anatomical posture. They used to walk, they used to sit like that. And normal hand function, weakness of the grip, ulnar deviation, and lot of the toe. So, J.L. King's identified these 6 speculations is related to and function. It's more than the by occupational therapist. Okay. So what she said, moreover, she hypothesized the person diagnosed having chronic schizophrenia have deficits in their reception of processing of proprioception and vestibular information. So these causes more psychotic symptoms. Okay, King suggested 2 things is very important: defective proprioceptive vestibular, defective proprioceptive feedback mechanism, then vestibular underreactive and underactive. So these two things, if it is new, just practice in your practice, okay? It's a defective proprioceptive feedback mechanism. What is that? So look this picture. The signal from the mechanical interaction, okay? The signal, neurons is taking the signal through the musculoskeletal, through the proprioceptor. The proprioceptors carrying the signals through ascending nerve root, through spinal reflex loop, okay, and it through the spinal cord, okay, through it, it will go to stimulate the cortical loop in the prefrontal cortex. So from that prefrontal cortex, okay, from the prefrontal cortex, so it's reflex modulation to spinal and musculoskeletal, it will give the mechanical action. Okay, so this is proprioceptive feedback mechanism. Think that if the signals, neurons is carrying the signals, okay, so in the brain, what happens? In the brain, what happens? So the chemical imbalances is there. So the signals is not properly. Maybe sometimes the proprioceptive feedback is not properly occur in the mechanical interaction. Okay. Look at this thing. Okay. The task performance through body movement, the muscle spindles take the signals through the reflex effects. For the muscle activation, how the muscle gets activated, central chemoreceptors and metatropic receptors through the metabolic energy demand. Okay, so it will give the metabolic cost feedback and the sense of effort feedback. Okay, so it will give the central processing. From here, it will give the proprioceptive feedback. So from that central processing, it will descend the command and to the muscle activation and the muscle forces through the Golgi tendon organs, then the system mechanics, it will give the task performance. Now we all understood what is the proprioceptive feedback mechanisms. Okay. What is vestibular underreactive and underactive? Okay, so we know the vestibular system is receptors in the inner ear and to the brain stem, to the cerebellum, oculomotor nuclei, spinal cord, and thalamus. So these are all the respective functions occurring in the vestibular. Okay, coordination from the cerebellum, coordination of the eye, head control, movement, posture, oculomotor nuclei. Okay, it steadies the eyes and the body movement. In the spinal cord, it influences the muscle and the tone of the muscles and the adjustment. Okay, and these are all the input. Okay, spatial perceptions and all. So how J.L. King speculated these vestibular thing, the vestibular involvement could be used to explain the S-curve schizophrenic posture, okay, which was probably a regression to the primitive labyrinthine reflex and characterized by flexion, internal rotation, and adduction. Okay, so due to this underactive or under-responsive or over-responsiveness of the vestibulation, the S-curve posture is there due to the vestibular thing. So, you know, we can see this area. S-curve posture due to this. Okay. So yes, so King hypothesized the underreactive vestibular system as indicated by abnormalities of post-rotatory nystagmus. Okay, post-rotatory nystagmus is difficulty in the oscillations of the eye during the rotation. Okay, so this is balance test. While you're doing that, so this is it will have an abnormal of the vestibular system. Okay, you can see this thing. The vestibular system is the under-responsive reaction to the input means its high threshold. What it will do, it seeks out excessive movement like spinning, swinging, and jumping and wiggling. You can see the schizophrenic patients, you know, they are little bit higher body shaking and all, spinning around maybe, and they are wandering around. Okay, this is the reason. And it appears constantly active, more personal boundaries and awareness. They are very aggression and then very active, very much wandering over it. Okay, this is all disorganized behavior also is there. So from the vestibular system. Okay? So through over responsive reactions to the input, and it's called as a low threshold. It avoids activities the more new, novel motor planning becomes very easily actually. So they are low threshold, low level of arousal level is there. So this is underreactive and under active. It's very important to speculate the thing. Okay, hope you all understand. Now, coming into the better part, how we advocate occupational performances in schizophrenia. Okay, so as we all read about that, what are the performance area we know, what are the client factors we know, what are the performance skills we know, sensory, perceptual, motor, praxis, emotional regulation, cognitive, communication, and social skill. These are the performance skill, performance pattern, context, and activity demands. So these are how I'll be going to advocate all those things to improve the sensory integration in schizophrenia. So the activities used could be recreational, and it's very important, like it's not should be in a competitive, it should be pleasurable and it should be a recreational one for them. That's what I said. We are planning one occupation. It's based on the need of the patient, priority of the patient. So it should be on a recreational way. The patient want to be enjoying that activity. So that's a pleasurable movement. So that's what I said. That's purposeful, task oriented. Okay, maybe the balloons or the beach ball, and also as we see in the 6 postural methods, the shuffling gait, escort posture, and all. So you can think in the mind, we need to be planned the activities opposite of the movement. The shoulder girdle and hand is inflexible mean my activity should be based on overhead activity. Okay, so the shuffling gait is there means I want the patient make to walk moreover. Okay, hand grip weakness is there means I want to make the patients more what hand activities. Okay? So this is very important. We want to be in the occupational performance advocacy. Okay. See the dynamic process of the sensory integrations. Okay, so this is the process of sensory integration in occupational performance. You can see this is the model of sensory integration. We know the discrimination. We need praxis, organization of the occupation, whatever the occupations may be. Okay, so look at that. This is a cyclic process. If I want to choose the sociability, social participation. So the modulations I want to plan from the sensory integrations. If I want to be planned the postural, ocular, and motor control, I want to take the adaptations of the interventions model in the occupation through sensory integrations. Okay, these are all the dynamic process. It will be a cyclic process to balance between the work, play, and leisure. It's a Bielik process on all the contexts. It will be having a temporality and a physical environment, social environment, and culturality. Okay. So I think we will be refreshed right now. Okay, it's not new slides for us. Okay, so we will have evaluate now. Evaluation means we know what evaluation on occupational performance. So in the schizophrenia, as I said, the two senses is more involving. Okay, proprioceptive feedback mechanism through and vestibular. Okay, in the results of proprioceptive and vestibular deficits, these are all the outcomes is there. It leads to motor retardation, psychomotor retardation. The patients walking very slow, retarded movement. Okay, they can walk an hour for a little distance. Okay, so immobility of the hand, the shoulder girdle movement, to resting posture and everything. So very slow rhythmic movements, they will be not active. So this is motor retardation, the lack of motivation, self-concept poor, and and impaired right-left discrimination, poor position in space, the visual perceptual deficit, and poor finger agnosia, apraxia, stereognosis, and general feelings of inadequacy and loss of pleasure. Okay, these are all I will evaluate through occupational profile and analysis of occupational performances. If I'm thinking a patient is not walking very fast, I'm taking psychomotor retardation. So I just want to collect the background according to that occupational profile, what the priority and desired outcome from the patient. Then I'm analyzing hello. Yes, I'm analyzing the dynamic transaction among the client, context, and environment and activity. Okay, so these are all very important to I'm analyzing and synthesizing moreover. Okay. So the intervention, I said very clear, you all following me, I think. Okay, the intervention is based on the 5 major goals actually. I will concentrate on the schizophrenic in the occupational base. What I want to be advocate, balance, posture, range of motion, spontaneity of the movement, and correction of abnormal hip and shoulder position. So these are all the 5. If you're recollecting the 6 postural proprioceptive movement is highlighted by J.L. King. So if you can think that one, so you can easily understand this. So I want to be work moreover all those things. Okay, so how I'll be correlated with this occupation, person, and environment through occupational performances through the following slides will be address that. Okay, so these are all some of the activities of the patients we can select. Some of the activities I cannot say these are all activities and applying the schizophrenic. So because we are treating the patients from the prodromal, recovery phase and also 3 phases. So one phases they are one perspective will be there. So this is very important. See the joint compressions, stretching, wall push-ups, peace ball, run, jump, skip, lifting, carrying, and push, pull, vacuum, sweeping. That's what I said. We will select the activities for the proprioception means I make the patient to bend and take something, or I just want to make the patient to clean. Can you please take down what is it? Can you take out? So, and at the same time, I can give the music also. So the client have the diversional activity and they can bend and they can do it. So how I can make these activities according to my occupational challenges, occupational findings. Okay, my selection of occupation. It's very important. Climb, crawl, okay, outdoor walk, okay. Is proprioceptive, right? So we can outdoor walk, fast walking, something like that. Okay, pillow fights and all. These are all the vestibular activities. Okay, like bouncing, jumping, swinging, balancing, and rocking. We have a rocking chair is there, so we can give the patients to rocking chair to rock over. See that swing set. Yes, we have a question. Can I use swing for the adult patient? Yes. So because it will be slow rhythmic movement, that's what I said. The duration, intensity, frequency is very important. So I can slow rhythmic pattern is yes. So because the vestibular part, while I'm doing the linear acceleration and the angular acceleration, the linear acceleration, the autolytic stimulate more. In the angular, the circular movement of the spinning, the semicircular canal of the vestibular organs is stimulating more. So very slowly, or not only in the suspended swing, or else maybe they can round over and they can turn the head like this and they can sit and spin, okay, like that. So we can turning, rotating, spinning, and they can in the group therapy they can turn and they can see the patient's backside. These kind of the activities is moreover incorporated to enrich the vestibular activities. Okay. This Ross, she said, therapy intervention based on sensory processing and motor planning model. This having a 5-stage orientation, movement, visual motor, cognitive, and closure. Okay, so this group therapy model I can use because my main aim is sensory to improve sensory processing in the adult. Okay, look at that one. Nice woman is sitting in the trampoline. Okay, and see he is bending it. So this is mediascar posture, inability of the raising, inflexibility of the hand. He is overhead ball. He is participating the overhead ball throwing. Okay. So this is very important. Okay, look at that position, what he did. So moreover, proprioceptive, more clubbing, proprioceptive, and vestibular. So my activity should be on that. So these are all the 5 stages in the group intervention model based on sensory processing and motor intervention model. Okay, maybe social participation is not there for the schizophrenic. So I'm taking the occupation as a social participation. So I just put the patient into these sensory processing motor learning model. Okay, so they can easily social participate, as well as I'm concentrating on their physical aspects. Okay, hope you all understand. Okay, coming to intervention implementation. Okay, so these are all I said: create, establish, maintain. We want to be refreshed, modify, and prevent. Why? How? So this is the thing. Okay, always the activity should be the subcortical. Okay, leads to or lead the feeling of mastery of the achievement. So short structured activity is very important, and I said it's not competitive, so they'll be easily get depressed and easily get tensed. Okay, aggressive because of the limbic system involvement. So we want to be more reinforcement in that. So the activity should be very pleasurable. So provide vestibular stimulation. This bilateral hand use to tone muscle against resistance. So both hand involvement is very important because the opposite movement of the what King speculated proprioceptive dysfunctions in schizophrenia. Okay, so that we will be counter the primitive and labyrinthine reflexes. Okay, so we are doing all opposite activity. We'll be counter and we'll be do an opposite activity for the primitive and labyrinthine reflexes. So it will be provide tactile stimulation on all the joints and tendons. Okay, so outcomes measure. We are so far we are seeing about the domains. Okay, how an advocacy through sensory integration for occupational performance in schizophrenia. So evaluation, intervention part, and outcome part. Outcome part, I said we want to be focused on more over their health actually. So the discharge plan. Okay, and their future recommendations also. So these outcome measures supporting the health and participation in the life through engagement in occupation. So the word, please, the budding occupational therapist, we must to use these kind of words. We'll be very from the professionals, So how was the engagement of the patient? What the participation? I'm working on the participation level, just like that. Okay. So look at that the thing. The outcome I'm based on the remedial interventions, the accommodations and adaptations. It's not very easy to, it's not very hard to understand. It's very easy to understand these terms. Okay. And my outcome is based on sensory diet program and environmental modifications and adaptations. Okay. And educations of the individuals. Okay, what are the remedial interventions? Okay, so in the remedial interventions, just recollect the intervention implementation. Okay, as we seen before, it's occupational based, it's advocacy based, it's consultation process, right? So in that thing, the engagement in the activities that provide for the schizophrenic to improve tactile, proprioceptive, and more movement opportunities. I want to give, if it is possible, suspended swing. I said there is no contrary studies shows that we cannot use various swings and all. Yes, we can use, but it should be based on their health, participation, and engagement. Okay, we can use the and maybe if it is too much balance issues, no, that's what I said. According to the phases, according to the stages, we can use for this patient. Okay. Some of the intensified physical activities engage in the mediated tactile experiences, some of the cooking, massages, and like that. Okay. Activities that promote motor planning, organization of the time, space, bilateral integration, and postural ocular skills. Okay. See the second, accommodation. How I'll be accommodate? Okay, maybe the patient is very sensitive in your clinic, and he is not supposed. I'm talking about schizophrenia only. Is not accommodate the activities that you have provided, and he's keep on having the ear. So you want to be adapt that what? So it's a very simple. We can have wearing the earplugs, noise cancellation headphone is there, so we can lot of noise headphone. This noise will be not there from the environment. So you can separate that. So using some of the sponge to shivering for the hypersensitivity and all. So some of the self-regulations for the active and passive activities for the work, household management, parenting tasks, according to this intervention plan. Okay, you can see the intervention review and all. So we want to be reevaluate, we want to be modify the plan, we want to be determine the need of continuation and discontinuation of the OT services and all. If the patient is not ready to accommodate and adaptations for over the 6 months and 8 months, so we want to be reconsider to consulting the psychiatrist again for their chemical imbalances level. So if the patient is not accommodate as well, so we need to be little bit our clinical reasoning is go on with the chemical imbalances. So we are not telling we are dealing chemical imbalances. Sure, psychiatrist deals with chemical imbalances, medicines and all, but I'm telling that sensory integrations, it will be change the environment, the frequency, durations, and intensity of the activity, sensory integration, activity, vestibular and proprioception. It will give more adequate responses to the people. Okay. So these are the sensory diet programs. Okay, a sensory diet is a personalized daily schedule of specific sensory activities and environmental modifications to help a client to stay calm, focused, and organized throughout the day. Actually, this is say as a self-regulation of the sensory diet. So you all may sure come across in this way. For the schizophrenic patients also, we need to develop, I said we need to develop a plan, focus a plan, okay, the future consideration. So if I'm discharging the patient, so I'm the occupational therapist discharging the patient with sensory diet programs. So either maybe the sensory rooms or the rocking chairs or yoga or swimming, whatever it may be, based on you are the practitioner, you are the or mentor for the patient. Okay, so you need to be think over what area the patients, I want to be modulate. Okay, so these are the environmental modifications, lighting, wall murals and sensory rooms, sensory stations or sensory cards. So these are all the environmental modifications and adaptations we want to be used in the for the patients. Okay. Okay. So and we are seeing the outcomes of the patients. Sometimes we need to be educations of the individuals. You can see the two thing actually. See, this is seclusion and mechanical restraint. Okay. So see, sometimes we want to be educate the family members and caregivers about the influence of the sensory functions on the occupational performances. Why it is because it's very important to change the occupation and change the dysfunctions actually. So because the patients from the residual phase or in the middle phase, there'll be very much hyperactivity. You can see the mechanical restraints. So these are the belt. You can see the tie of the leg and thigh and neck, hand, and also all over the medical, in a psychiatric hospital, you can see the uncooperative and very hyperactive patients. They are mechanical restraint. Okay, the evidence-based practices shows nowadays occupational therapists entering and they are inside the inpatient ward. They are creating the sensory rooms and the diverting mechanism, maybe example light, I said environmental modification, lighting, and there's some of the suspended equipment, some of the big therapy balls, okay, some of the walking equipment, music. So it will be divert from the restraint. So a lot of the nurses, they are telling that. Okay, so see the this is what the proactively help the inpatient to prevent, de-escalate from the maladaptive behaviors. So seclusion, they are not restraint. This is restraint. Restraint, there is 3 restraint is there: mechanical restraint, physical restraint, and chemical restraint. Chemical means they are put injection, sedative, psychopharm they are giving. Okay, and physical, this is a physical restraint. They can 2 to 3, 4 nurses and the healthcare workers, they are blocking backside. Okay, and this is mechanical restraint. So see the patient, if they are restrained like this, how their adaptive behavior and sensory experiences will be. So we mental health occupation, especially mental health occupational therapists in these setup, we will be too much knowledge about that. So I have an experience in this area. Actually, I'm working in Kuwait Ministry of Health, Kuwait Center for Mental Health. So we used to be go adolescent unit, an adult unit, and geriatric unit. In the adult unit, sometimes with this we go, so we can able to see this strength of the patients. The very initial part, acute phase, is very resting because the Schneider's first rank symptoms is debilitating them. Actually, they'll be fighting in between the positive and negative symptoms as well. Actually, so they're beginning killing themselves and all. So I cannot say all the patients are like this. Some of the patients like that. That's what the occupational therapist assessment is very important to advocate the occupational performances along with sensory integration. So I'm seeing these kind of patients. Okay. And coming to seclusion, they're not restrained through like this. They'll be locked in one door with one mirror seeing, where they can see whatever in outside. See, this is how aching, So that patients and all, we want to be assessed and we want to be making to independent. This is what Lorna Jean King, she speculated moreover vestibular and proprioceptive part, much more involvement to advocate the occupational performances. Okay. Hope you all understand this thing, mechanical restraint and circulations. For we need to be educated then. Okay. These are all some of the evidence-based practices by J.L. King. Okay. Some of the research article from Australian Journal of Occupational Therapy 2010, their findings, the participation of occupation in the community development. Okay. In 2017, International Journal Nursing, the sensory rooms could provide occupational therapists with a better tool for reducing distress adolescent in the psychiatric unit for the aggression. I said seclusion and restraint. Okay. In March 2007, American Journal, they said, activity level, occupational engagement, and satisfaction with daily living occupation, SGO. That is, this is one standard assessment used for schizophrenic patient. Okay, so in that they can know their character, self-esteem, and their daily living occupation, and so on. Okay, so these are the recent exploratory studies of occupational engagement we need to know the profile of occupational engagement of among the patients with severe mental illness. It's called POES, P-O-E-S, Profile Occupational Engagement Scale. So this is a good actually we use for schizophrenia. This also have a very good have a regression analysis results. Okay. Thank you. This is my end of the slide. Our occupational therapy plays a vital role in identifying and treating sensory integration problems in schizophrenia, schizophrenic adults, and supporting the ability to fully participate meaningful life roles and routines and advocate daily activities through engaging occupational performance. It's from Scandinavian Journal of OT. So I hope you all understand today what the sensory integration of through occupational performance level for a for a schizophrenic patient. So we have learned a little bit today how the occupational performances apply for the schizophrenic to sensory integration. So this is what the great impact of sensory integrations to advocate occupational performances in schizophrenia. Okay, these are all my references. It's my journals. From Occupational Therapy Practice Framework, 2004 edition for the domains and practice process. Thank you.
Thank you, sir. Participants, you can come up with your questions. You can ask one by one. Any questions?
Good afternoon, sir.
Yeah.
It was a really extensive presentation, sir. Thank you for giving such a wonderful insight.
Yeah.
Sir, I have a doubt. You've mentioned about sensory room for calming agitative adults. Right, sir? Can you give a more insight on it? If a schizophrenic patient with schizophrenia is having visual hallucinations, how will we design the sensory room? Because wall murals with animals and images might trigger further hallucinations for them, right, sir?
Yes, yes, yes.
How?
Actually, I said, I got your question, sensory rooms. So actually, I said this all the activities is not all applicable. For, as you said, the visual hallucination. So we study about the positive symptoms and negative symptoms, right? So we will be not apply all the schizophrenic patients into the sensory rooms, okay? So we'll be going with the negative symptoms, the residual patients and the last, chronic schizophrenia. Acute phases, there'll be positive symptoms. Moreover, they'll be all in the medicine setup, actually, antipsychotics area, antipsychotics term. So the chronic schizophrenia only. So for them, we can adapt a little bit, because in that residual phase, as I said, if you go on the slides before, the residual phase, moreover, positive symptoms is reducing, okay? And the negative symptoms, like withdrawal, apathy, like that. So for them, we can use this sensory rooms. Sensory rooms you can adapt according to your, yes, that's what I said, yeah. Hope I answered your question.
Yes, sir. Thank you so much. Sir, one more question.
Yes.
The activities you've mentioned, what kind of activities we can suggest as a home program for the caregivers?
Home program, maybe for what type of schizophrenia? Maybe general schizophrenia?
Sir?
General schizophrenia, or what? Any type of schizophrenia that you mentioned?
Maybe catatonic or something else, or paranoid.
Okay. Yes, yes. So I said the let's say the schizophrenics. Okay. We are expecting the 6 proprioceptive difficulties, right? Proprioceptive and vestibular difficulties. Okay. As a home program, we can advise a rocking chair. Okay. We have a rocking chair. Easy chair is there. We are Indian communities they're using actually. So in that we can rocking chair is and moreover periodical music for the diversional technique to make them to engaging actually. So all the times, as I said, the sensory diet is engaging their time, right? So we need to be put some of the times. These are the activities: rocking chair, music activities, and the TV activities. Okay, we need to be put the scenario in it. So it will be more precisely for the home program.
Thank you so much, sir. Thank you.
Right, right.
Sir, there is one question from chat.
Yeah.
How schizophrenia can be treated while staying at home during this unpredictable pandemic? That is, what are the guidelines to be given to the patient when they are at home?
Okay. Yeah. The skills I see in the chat can be treated while staying at home. Yeah, because it's again I'm telling it depends upon the stages on the phases of the patient. If they are very positive symptoms patient, you can touch with your psychiatrist definitely through phone and all the medicine, because the active phase they are very too much hallucinating, positive symptoms exposition. Okay, so for the I said the restraint, if it is very difficult, very severe cases, the chemical restraint is done by it's given prescribed by psychiatrist. If we even to coming to the chronic state, in the social withdrawal state, as I said again, so we need to be engaged according to the occupational process. I said so we need to be look over what are the domains he's affecting and how I can engage in all the domains. I know this is not very easy to handle it while we are in experiencing. We come to know about the patient actually. So we will be study first of all the performance skill and performance patterns. So this it will be create a very good predictable environment to them. Just give one put on chart over it. Okay, what the patients what the plan, okay, and what the outcome and how I want to be doing that. So what the occupations they are affected. Okay, so if you know the clear occupations, so we will be get through it very clearly. Is schizophrenia curable? Is there any evidence? From Shivam, it's not curable. It's a neurodegenerative process. I'm answering Shivam. It's a neurodegenerative process. Yes. Hello, someone is asking.
Good afternoon, sir. Hello.
Hello, Derek. Your voice is breaking.
Yes, your voice is breaking.
You can put up your question on the chat, Derek.
Okay, and we'll go for the chat question now.
Yes, sir. Yes, sir.
Yeah, okay. Yes, actually, Shivam, she asked, he asked, is schizophrenia curable? Is there any evidences? Yeah, I said again, schizophrenia is not curable. It's a neurodegenerative disease. Okay, the psychotic disease. We will be rehabilitating them. Actually, there is no evidences for it. If it is a patient's first stage, if it is only 1 month, they easily come up for the medicines and they are. But immediately it's according to their diagnostic organisms. How they are fighting with a genetic predisposition, how they are fighting with chemical imbalances, and how they are engaging with our occupational performances, sensory integration. So it says so actually. So according to that only we are, there's no evidence till now telling that. What are the lovely Gupta? What are the earliest sign to detect childhood schizophrenia if their parent has it? So childhood schizophrenia, the same thing, like autistic spectrum disorder is untreated, it will be go on with schizophrenia. The evidence is there. Okay, so definitely we need to be clearly given a sensory integration therapy for autistic spectrum disorders. So if it's untreated, sure, all the schizophrenia, if we go on with, I said, occupational profile, we can collect the occupational profile. Definitely there's a history of AST. Okay. For this, we want to be, if it is child is go for with autistic something like that. So we need to be go for a psychiatrist associated with occupational therapist. So we need to be diagnosed first what the child have. Is it childhood schizophrenia or not? So the diagnosis is very important. Why? To see that. Okay. What are other neurophysiological responses they experience to other senses other than sensory gating and mismatch negativity? Actually, this is from Sandhya Parthasarathi. Okay, so actually, this auditory evoked potential and auditory event potential through sensory gating and mismatch negativity, this is only is evidence based. They are read over to take over in our articles actually. Hope maybe some other senses and some other physiological responses can be on the research. Okay, but this too, the sensory gating and mismatch negativity is the neurological processes taken in our study, and it's proven in our journals and articles. So this is what right now, and other senses, it's not a proven and still also is on research actually. That's what my opinion about that. Please explain the stages of recovery in schizophrenia. Again, I said the stages of recovery is based on the stages of schizophrenia. Okay, and how the participation level will be, how the engagement level will be. If untreated, definitely the patient will go on very poor prognosis only. So as I said, in the menopause time, women easily get men is very low prognosis. So it's according to that stages only the recovery thing will be. And if in this recovery phases, we are interpreting the dynamic process of the sensory integrations in the daily living occupations, it will be great for the thing. Thank you. I think I answered the chat. We need the chat. Thank you. Yes. I think hope you all understand. First of all, I want to be hear from you. Any one or two from your feedback. Is it clear? Is it you can understand the advocacy of sensory integration through occupational performances? Is it useful?
Sir, there is one more question in chat.
Yes.
Patient with
Yeah.
paranoid schizophrenia. Yes,
I
okay.
Patient with paranoid schizophrenia and be in continuous self-isolation or quarantine in this pandemic situation can also lead them stressful and might trigger a psychotic event. Okay. Can you prefer some goals and activities to treat them? Okay. So for their goals, is based, they are paranoid, right? They are quarantined, they are paranoid, little bit psychotic event is there. Okay. So this also, and again I'm telling, we want to be, he's in right now the situation is the environment is very much debilitating, right? So we want to be think over this patient for the context and environment. So we want to be think over the physical, cultural, social, temporal context. Okay, so we need to be. He's not all over the inside the room only. It's not seclusion, right? If it's seclusion, we cannot do. We restrain our seclusion. Otherwise, at least from outside a little bit and home around. Upstairs, like upstairs, I'm telling, okay, nowadays we cannot going out. So upstairs, just having a walk. So this walk, paranoid, because these are all the proprioceptive vestibular thing by King speculation. It's non-paranoid patients. But this patients, first of all, he needs to be recovered through this stage, first of all. Okay. Then we can take into the improve the proprioceptive and vestibular functions to walk and all. So I think this continuous isolation, because he said his self-isolation is there. So that's what we want to be making to engage actually. You can think what occupation is affected for them. So if you say some specific occupation, we can plan the intervention plan. So as I said, to evaluate intervention plan and outcome. So just now we want to be here to focus on the health and situation. Okay, I think I answered Derek.
Yes, sir.
Yeah, thank you.
Arun sir,
You can ask.
question sir.
Okay, thank you, Vinith. நீங்க
sir.
நீங்க photo tag சொல்லலாம்.
Okay. Thank you, sir. Thank you for sharing your knowledge to us. It was a wonderful session, sir. Thank you so much. Sir.
Thank you. Thank you, and
Thank you, Vinith.
yes, thank you so much for your all participants in this presentations. I hope I know this is a little bit new venture. I'm very sorry for my bad audible. Okay, it's fluctuate during the quarantine time. Like the internet facilities also. I'm sorry. Okay, and thank you all the participants, and thank you Dr. Arun Kumar and Savita team. Thank you so much.
Thank you, participants, for your patience listening.